This case study on congestive heart failure is the collective work of Rochelle Lowe, Tin Bowie, Haywan Mikonen, Leisha Hansen, and myself, Angela Naide. Mrs. Smith is a 67-year-old female who presents to the emergency room with complaints of increased shortness of breath, swelling in both of her legs, as well as chest pain. She has little medical history available and admits that she doesn't go to the doctor unless she has to. Her chart indicates an echocardiogram from 5 years ago, with a resulting ejection fraction of 40%. She reports a previous history of heart attack, coronary artery disease currently unmanaged, and she's a pack-per-day smoker. She had pizza for dinner last night and thought she was having severe heartburn. She is anxious and states she feels worse when she lies back on the bed. Her lower extremities are swollen, which she states they're always that way, and she's not too concerned about it. She has 3+ pitting edema in the legs and bilateral crackles in the lower lobes of her lungs. Her blood pressure, heart rate, and respiratory rate are elevated, and her oxygen saturation is 90% on 4 liters of oxygen. We've got X-ray results back which indicate an enlarged heart and consolidations in the lungs. She also has elevated cardiac markers indicating myocardial injury and abnormal electrolytes, which could indicate fluid overload. Congestive heart failure is a complex clinical syndrome that can be caused by a functional or structural disorder. The ventricle's ability to fill or eject blood is impaired, resulting in poor peripheral perfusion and pulmonary vascular congestion. Blood and fluid back up into the lungs, which manifests clinically as fluid overload. Overall, cardiac output is inadequate and unable to meet the metabolic needs of the body. Statistically, about 5.1 million people in the United States have heart failure, and 1 in 9 deaths in 2009 included heart failure as a contributing cause. About half of people who develop heart failure die within 5 years of diagnosis, and the medical costs are an estimated $32 billion each year. Left ventricular failure is the most common presentation of heart failure, and often leads to right ventricular failure. Clinical manifestations of left and right ventricular failure are different because of the location of the congestive process. Dyspnea or shortness of breath is a primary presenting symptom and is worsened by activity, dyspnea on exertion, as well as lying down, orthopnea, and paroxysmal nocturnal dyspnea. Other clinical signs include cough, respiratory crackles, which is the sound of the movement of air through partially filled alveoli. In severe cases, we may see frothy, pink-tinged sputum from breakage of capillaries and fluid buildup in alveoli. Left ventricular failure eventually increases the workload to the right ventricle, leading to right ventricular failure. Clinical symptoms of right-sided heart failure include hepatomegaly and ascites, anorexia and GI bloating, jugular vein distension, generalized edema or anasarca, and increased weight, as well as anxiety, depression, and fatigue. Again, here we see the clinical portrait of congestive heart failure. You can see here the fluid in the peritoneal cavity, or ascites. Skin is pale, gray, or cyanotic. Patients are understandably experiencing a lot of anxiety due to difficulty breathing. Decreased oxygenation can cause confusion and even unconsciousness. You'd also find a weak pulse and moist, cool skin, distension of the jugular vein, and maybe nausea and vomiting. Here we can see the pitting edema and jugular vein distension. In the image on the left, you can see the pulmonary edema, or excess fluid in the lungs. Swelling in the belly or ascites is indicated. Obviously, fatigue and shortness of breath. The weaker pumping action of the heart, and the swelling in the legs and ankles. Congestive heart failure is caused by heart disease, commonly related to coronary artery disease, or by problems with circulation, such as with volume overload. It's the result of anything that causes decreased blood flow to the heart muscle, such as with problems with the arteries, as in coronary artery disease, or damage to the heart muscle, such as with infection or alcohol abuse. It is also the result of any problem that causes the heart to overwork. An MI or heart attack causes death of the heart muscle due to the ischemic event. Hypertension leads to left ventricular hypertrophy, making it hard to oxygenate the heart muscle. Obesity and diabetes can lead to coronary artery disease. In cardiomyopathy, the ability of the heart to pump blood is decreased and can be caused by alcohol, fibrosis, or infection. Regarding collaborative care, diagnostic, we would look at the history and physical examination. Determine the underlying cause. Lab studies might include serum chemistries, cardiac enzymes, BNP level, liver function test, chest x-rays and 12-lead ECG, echocardiography, exercise stress testing, nuclear imaging studies. We would also want to consider hemodynamic monitoring, where we would measure the venous, systemic, pulmonary pressures, and cardiac output to determine tissue perfusion. And cardiac catheterization, which is a catheter into the heart to visualize coronary artery disease or valve disease. Therapy would also include determining the underlying cause. Oxygen therapy at 2 to 6 liters per minute, rest activity periods, drug therapy, daily weights, and sodium-restricted diet. Drug therapy would include diuretics, morphine sulfate possibly, vasodilators, B-adrenergic blocker, angiotensin II receptor blockers, antidysrhythmic drugs, among others. Patient education is a critical component in treating and managing patients with heart failure. Teaching points should include signs and symptoms of heart failure, body mass index, medication management, and diet. Limiting the following risk factors will slow the progression of heart failure: hypertension, obesity, poor diet and lack of exercise, smoking, and alcohol. A lot of controversy surrounds whether light to moderate alcohol consumption can provide anti-inflammatory effects. Some studies have supported this theory, but all agree that excessive alcohol use should be avoided. Administering prescribed medications such as diuretics, beta blockers, ACE, CCB, and having ARBs, a program directed toward heart failure management, which is often nurse managed, demonstrated 56% fewer rehospitalizations, 61% fewer admissions, and 36% fewer days spent in the hospital. More nurses should specialize in heart failure because it is shown that specialist nurses play an integral part of patient outcomes, significantly reducing readmissions, length of hospital stay, hospital costs, and mortality. It takes a multidisciplinary team to effectively manage heart failure patients. There are multiple issues to address, such as polypharmacy, symptom awareness, self-management, follow-up care, changes to lifestyle, diet, exercise, daily weight, stressors, finances, and support. The Joint Commission identifies 6 areas of focus for patient education regarding heart failure: diet, exercise, weight monitoring, worsening symptoms, medications, and follow-up appointments. In a study of heart failure patients of various ethnicities, greater understanding of these 6 topics was significantly correlated with lower rates of hospital readmissions within 30 days of discharge. We'd want to educate the patient about diet as appropriate, including heart-healthy diet, sodium restriction, no salt added, and fluid restrictions. We'd educate about the importance of regular exercise and provide specific instructions about activity level as appropriate, such as regular exercises tolerated, rest periods as needed, no strenuous exercise, and cardiac rehab. We'd also educate about the importance of recording daily weights at the same time every day, on the same scale, and with the same amount of clothing. We'd instruct patients to notify or visit their provider or seek emergency care as appropriate for worsening heart failure symptoms, such as increased edema, ascites, weight gain of 2 pounds in a day or 5 pounds in a week, dyspnea, worsening cough with or without pink-tinged sputum, activity intolerance, syncope, tachycardia, and chest pain or pressure. We'd also educate about the importance of taking medications as ordered. We'd want to inform our patients when we schedule a follow-up appointment and educate about appointments needed with the provider as needed. Another consideration is a heart failure action plan for home management, which can help a patient recognize symptoms associated with heart failure and know when to follow up. We need to consider the cultural and socioeconomic status when providing the education. We need to assess the ability to pay for healthy foods, medications, and follow up on medical care, such as if they're insured. We need to refer to free or low-cost health services within the community as appropriate. Culture foods that should be encouraged or restricted based on ordered diet. And we'd want to consider education level, health literacy, ability to speak or read English, adjust teaching methods to provide the education materials as appropriate. And that's it for our case study on Mrs. Smith and congestive heart failure.